Hello everyone, this is Dr. Kunal Patel. I'm a pulmonary fellow at Jamaica Hospital, and this is the first in a series of case presentations in pulmonary and critical care. The following material presented here has been taken from various resources and is to be used for educational purpose only. This was a 64 years old male who presented with progressive shortness of breath and leg swelling. Patient had a significant history of non-small cell lung cancer, which was diagnosed 18 months ago and was being treated with chemotherapy and radiation therapy. Patient had the symptoms for many months but had been worsening in the last month to an extent where he could hardly walk to the bathroom. These were associated with dry cough and pleuritic chest pain on the right side. He also had an associated weight loss of 15 to 20 pounds in the last 4 months. Patient was on home oxygen and he denied any fever, hemoptysis, or loss of consciousness. Patient had undergone a chest tube drainage and a pericardial window last year for large malignant pleural effusion, which was associated with cardiac tamponade. He had reasonable recovery post-procedure. Review of systems was positive for malaise and fatigue, and there was drainage of fluid from the right chest wall side, most likely the insertion of the chest tube. He had a past medical history of pericardial tamponade. He also had surgical history of VATS and a pericardial window, and he was on erlotinib, also known as Tarceva. Social history: he had a 40-pack years history of smoking and he quit smoking 1 year ago. He did not consume alcohol. He did not have a history of IV drug abuse. On physical examination, he was moderately built, cachectic. He was ill-appearing and in mild to moderate respiratory distress. Hemodynamically, he was stable, afebrile, but he had tachycardia with a pulse of 110. He was saturating 98% on ventimask 40%. Respiratory system: he had diffusely decreased breath sounds on the right side. Left side was clear. There was no wheezing, and there was stony dullness to percussion on the right side. He also had a right chest wall defect with a red nodular lesion and a granulation tissue versus tumor protruding from this defect. He had bilateral pitting pedal edema, but the rest of the examination was benign. On labs, CBC BMP was normal. He had a bicarb of 29. ABG on 40% ventimask was 7.46, 41, and PO2 of 133. His EKG showed sinus tachycardia. And this was his chest X-ray on presentation. As you can see, he had a complete opacification of right hemithorax. The differential here includes a large right-sided pleural effusion. He could also have had a collapse of the right side. And the third differential for a hemithorax opacification is the large mass or consolidation. Here you could see that there is a sense of the mediastinum being shifted to the left side, and there's not much of narrowing of the intercostal space. Also the right hemidiaphragm is not clear, and there is blunting or absence of the costophrenic angle. So all this point towards it being actually a right pleural effusion than the other two differentials. This was his CAT scan, and as you can see, the patient is lying on the table. This is the table. This is the anterior part. You are seeing from the feet up, so this is the right side and this is the left side. There are two different densities that you can see. The density that you see inside is actually the lung. This is the collapsed lung sitting here, and this is most likely secondary to the large pleural effusion which is surrounding the lung. As you can see, I have also labeled the visceral pleura, which is right on the lung, and the parietal pleura, which is right inside of the chest wall. This is a coronal section of this of the same CAT scan, and you can see that there is a large pleural effusion causing a collapse of the lung right here. So the patient actually underwent thoracocentesis, and once the thoracocentesis was done, the post-thoracocentesis chest x-ray showed that the patient had still there was some fluid, but there was a large pneumothorax and the lung never expanded. Also, you could see some subcutaneous emphysema here. Seeing that x-ray, patient had a chest tube which was inserted, but despite of the chest tube being inserted in the right sense, which is it is going anterior and it is going superior, which is a good thing for a pneumothorax. If you wanted it primarily for a pleural effusion, you would put it posterior and you would put it inferiorly. That way you could have all the fluid getting drained. Here you're trying to drain the pneumothorax also, so you've put the tube more superior and anterior. You could see that the pneumothorax has actually not resolved and the lung is still sitting here. Subsequently, patient had a placement of an indwelling tunnel pleural catheter and chest tube was removed. Patient was discharged with the indwelling catheter. This is just to show how the indwelling catheter was placed. They put a guide wire through the chest tube and the chest tube was removed. This guide wire, which is seen under fluoroscopy, is actually inside the pleural cavity currently. And you could see that it is a subtunnel in the sense that it is subcutaneous for about 3 to 4 centimeters before it comes out. This is done so that the infection doesn't seep directly into the pleural cavity. So let's say if you have an infection of this tube, most likely it will occur at the site of insertion and it will be pertaining here rather than it coming all the way into the pleural cavity. So this brings us to the topic of unexpandable lung. It basically means that there's an inability of the lung to expand to the chest wall, so that there is no apposition of the normal visceral and the parietal pleura. This could be secondary to direct result of visceral pleural restriction, as probably is in our case with malignancy, tuberculosis, or just inflammation and fibrin deposition, or it could be secondary to an endobronchial obstruction, which could cause a collapse and atelectasis. If this keeps going on for a long time, you could have an unexpandable lung. What are the causes of trapped lung? Most important is surgical procedures on the chest, like coronary artery bypass grafting. Also secondary to MI and post-cardiac injury syndrome, empyema or a complicated parapneumonic effusion if not drained for a prolonged time, uremic pleuritis, hemothorax again if left alone and not drained after a prolonged time will cause inflammation of the visceral pleura and a trapped lung. Radiation pleuritis and rheumatoid pleurisy are the other causes of trapped lung. How do you suspect and what is the clinical presentation? Basically, if you have development of an unexpected pneumothorax, as was in our case, where you had very easy thoracocentesis with retrieval of fluid without any complications, and yet you ended up with a pneumothorax, it should give you a hint that probably the lung is trapped. The inability to fully expand the lung in spite of a pleural tap with draining of the fluid, and again inability to completely drain the effusion due to the development of substernal chest pain. This is all clinical presentations. This third point basically is telling you that when you are draining this fluid, suddenly there is so much of negative pressure that is being built up in the pleural cavity that it just sucks the air inside and causing a pneumothorax, giving rise to substernal chest pain. So unexpandable lung basically is categorized under two entities. First is lung entrapment. This is the early phase, and the second is a trapped lung, which means that if this lung entrapment has been going on for a long time, you get a trapped lung. Once you have a trapped lung, in spite of removing the underlying pathology, the lung will not expand. So as seen here, this is beautifully described in an article which came in 2007 in the journal Chest. You can see that initially you have inflammation that causes an exudative effusion, or you could have a hemothorax here. This inflammation, when it keeps going on for a long time, you start having deposition of collagen. So over a period of time, although the inflammation goes down, the collagen deposition has been happening. Now, over a period of time, this non-specific fibrinous pruritus, which initially was just inflammation with exudative effusion, turns into a fibrous peel. So this collagen has been deposited for a long time, causing a fibrin peel over the visceral pleura. Once this happens, the lung becomes trapped, and now even if you have drained the fluid away, this lung will not expand, unlike in lung entrapment, where if you would have taken some action and removed this hemothorax or a empyema or a complicated parapneumonic effusion, this lung would have expanded. So over a period of time, it's called a trapped lung. Again, as you can see here, the pleural space has an injury causing an exudative pleural effusion. If there is resolution, you have pleural apposition and patient normalizes. If no, you have lung entrapment. This is the first phase of trapped lung. If there is continued defective repair, then you end up getting a trapped lung. And importantly, when you tap these patients with trapped lung, most of the times you get a transudate. Of course, if you have a malignancy with pleural involvement, you could still have an exudate, but there is still a chance that you could have a transudate here. So how do you diagnose this? The gold standard is still a pleural manometry. This is, you basically measure the intrapleural pressures, as I'll show you in the next slide, when you are doing a thoracocentesis, and depending on the measurements, you could say that the patient probably has an underlying trapped lung. There's also an investigation known as air contrast chest CT, where you actually use air as a contrast medium and see if there's a trapped lung. And again, if you do not have the facilities for either, when you do a thoracocentesis and you have a chest radiograph post-thoracocentesis demonstrating a loculated basilar pneumothorax, could give you a clue that there is an underlying trapped lung. So what is a pleural manometry? Basically, when you have a pleural effusion, the pleural pressures are positive. So to begin with, in a normal pleura, you have negative intrapleural pressure, and this is very important in the expansion of the lung. It keeps both the pleuras opposed, and so when you breathe, the whole lung expands with the movement of the chest wall. When you have pleural effusion, this negative pressure becomes more positive, since there is fluid which is exerting pressure. Now, as seen in a normal pleura and a lung which is not trapped, as seen by the square black line, when you start tapping the fluid gets removed and the pleura becomes negative, but only up to -20, which is the range for the normal intrapleural pressure. Against that, if you see that if you have a trapped lung, which is shown by these black triangles, you see that the pressure becomes negative, but suddenly, as the lung is not expanding, the pleural effusion that is getting drained is actually causing a vacuum, which means that there is a very high negative pressure, and it would just suck air in, causing a pneumothorax. And this is shown by the sharp decline in the negative pleural pressures. So the current guidelines indicate the following to terminate fluid removal when you're doing a thoracocentesis, and if the patient has anterior chest pain, if your mean pleural pressures are becoming more negative than -20, so becoming -30, -40, or if you have intractable cough. These are the guidelines for stopping a thoracocentesis. This brings us to the management. The most important part of management is actually the prevention. If you could prevent this trapped lung, that would be the most important thing, which means that if you have a hemothorax, if you have an empyema, you want to quickly drain these things. If you leave them alone for a longer time, you're going to end up having inflammation of the visceral pleura and a trapped lung. So let's say if the patient comes after the patient has already developed a trapped lung. If the patient is asymptomatic, you just observe the patient. If the patient is symptomatic, you will have to do a surgical decortication. And it's important to note that a decortication has been shown to be successful even years after the initial pleural space insult. The last thing is there's no evidence for the use of steroids here. So the most important thing again here is prevention rather than treatment. So this brings us to the end of our first video podcast in the series of pulmonary and critical care case presentations, and I would want to thank Doctors for Afghanistan for their tremendous work and giving me this wonderful opportunity to help the developing medical community in Afghanistan. Thank you.